Top Bed Talk.
Monty Mython here. As we prepare to move into the next phase of the COVID crisis, we're going to be widening our focus here on Top Bed Talk. We will continue to deliver COVID-specific programs, but we all have a huge additional responsibility as we try to reboot normal services. So although this piece is not directly related to COVID-19, we believe it's information that is crucial to the bigger task of rebuilding the healthcare system as we learn to adapt and live with this new virus. Thank you to our sponsors and to you, our listeners, for helping us to share this important information.
Nick Majerison here. Today's piece is an EBPOM Highlight. Well, this week we're focusing on EBPOM as we get ready for EBPOM Live from London, the groundbreaking perioperative medicine conference that you can attend without having to leave your bedroom. Ensure you attend EBPOM Live from London. Go now to ebpom.org and find out more. ebpom.org.
Our next speaker, Linda Denehy, perhaps wins the award for the furthest travelled faculty member, coming all the way from Australia, where Linda is a professor and head of School of Life Sciences at Melbourne University, has a clinical practice at the Austin, and for 30 years has been involved in the rehabilitation of critical care patients. She's a researcher, a grant-awarded clinician, and is here to tell us a little bit more this morning about rehabilitation of the critically ill patient. Linda, thank you.
So I've been asked to talk about rehabilitation in critical care environment, and I'm used to speaking to critical care people rather than perioperative medicine people. But in the next 20 minutes, I just wanted to go through perhaps some of the unknown unknowns, as Denehy was saying, around critical care, and agree with her that the fact that it's not a great place for people who are well and really don't need to be there. So we're hoping, certainly, and also I should talk about my bias. I'm a physiotherapist, so I'm a little biased around rehabilitation as well. But we're hoping that when patients come to the critical care unit, certainly if they're elective patients, that they have already had, and they're high-risk patients, of course, that they've already had some prehabilitation, because, as you know, in this environment, patients who have education, so this is a study that we undertook that was published at the end of last year, with just one education session preoperatively in 441 patients, that patients, and we measured post-op pulmonary complications, and we actually found a 50% reduction in post-op pulmonary complications. So the intervention was only education about breathing exercises, about what's happening to the lungs, and about mobilisation, and about mobilising as much as possible, improving physical activity before they come to their surgery. And there was a significant difference. There was also some separation in mortality at 12 months as well in this study. There's also a new study that was presented in Eindhoven, I understand, from the Spanish group, showing the same sort of thing. So this is prehab. The intervention was motivational interviewing and specific exercise, and again, a 50% reduction. We know that patients that come to critical care who are fitter, who have a better muscle mass, will actually do better, and I'm going to just go through why that is. So what happens when patients do come to critical care? And obviously a lot of patients are emergency and do end up in the unit. Well, we know patients lose muscle mass, and this has been termed intensive care unit acquired weakness. It's a very heterogeneous definition. It's around polyneuropathy, polymyopathy, a combination of the two, and results from immobility as well. But this definition from the American Thoracic Society is a clinical one. It's measured using the MRC sum score, which is a manual muscle test, 6 muscle groups on each side. Out of 5 adds up to 60, and if you score less than 48 out of 60, clinically you have this heterogeneous phenomenon called intensive care unit acquired weakness. Now, there is some emerging evidence that if you start with a better muscle mass, then you're not going to end up as weak in the ICU. So the pre-op is really important, and the prehabilitation is really important for our patients. We also know that it's actually prevalent. So it's more prevalent than other complications in patients in the ICU. So in a recent meta-analysis that we undertook, we had a 40% incidence of ICU AW, That was in the last 10 years, and the 10 years before that, in a previous meta-analysis, it was 46%. So it hasn't actually changed that much. It's an important complication of being in ICU. The other thing that we know is that changes in muscle mass are rapid and early in the ICU. So this graph shows the changes in the cross-sectional area of rectus femoris on the y-axis and time from admission to the ICU on the x-axis. This is from Zuidenputter-Cherry's group in the UK, and you can see here this decline in muscle mass in the first 10 days of around 20%. We actually did some work in a smaller group, one of my PhD students, and found indeed exactly the same in a unit in the Austin Hospital in Melbourne, exactly the same pattern. It was even worse. It was a 30% reduction in muscle mass. Ultrasound is a really easy way of measuring weakness, so to speak, because it's non-volitional. The problem with the MRC score is it's volitional, so patients need to be cooperative and awake to be able to do that. And they're not, obviously, in the first few days of ICU. And whether they're cooperative really after that, it's very hard to know. So these non-volitional testings have become very popular in the ICU. However, they have problems. So ultrasound and cross-sectional area may not be the best to use because initially you might be measuring fluid as well in that cross-sectional area. So what the field is turning to more now in using ultrasound is to use echogenicity, which looks at muscle quality. So you can actually look at the muscle quality using an ImageJ program, which isn't difficult. And there's some evidence to suggest that when you see much more white on the ultrasound, that may be indicative of muscle destruction and muscle changes. So ultrasound's a great non-volitional technique of looking at muscle mass, but we need to be a little bit careful about how we interpret it. So muscle mass reduces. In our study, the muscle mass reductions did have about a 0.5 correlation with function, but muscle mass strength and function aren't necessarily correlated. So just because you have less muscle and less strength doesn't mean you can't function properly. So we're looking at why that is and what it is about the muscle that is causing that at the moment. So there's a lot of work happening in the field around muscle biology. The other thing that we know is that muscle mass reductions are worse in multiple organ failure, and that makes sense. So the green here is the single organ failure, a 7% loss of muscle mass. But you can see here with 2 and 4 organ failure, that percentage of muscle mass is higher. So severity of illness, obviously patients are worse. And so that really makes sense. Again, that's from Zuidenputter-Cherry's work. We've also had, since the seminal paper, this one here from the New England Journal by Margaret Herridge in 2003, so it's 15 years since we've recognised that patients leaving ICU have disability problems, have functional problems, have health-related quality of life problems, right up to 5 years, when she followed her group up to 5 years. And there are also newer papers here, the lower two from the Victor Dinglass from the Baltimore group, showing that patients at 5 years still have muscle weakness. So these are really important papers because it's tying together what we're actually doing to patients in the ICU and for when they leave the ICU. In 2011, there was a consensus conference, and the reason behind this consensus conference is to sort of recognise that people in the ICU, and call it PICS or post-intensive care syndrome, have not just physical impairments but cognitive impairments, mental health issues, and that also their family has mental health issues. And really, if you think about it, that makes a lot of sense. The reason for this consensus conference was that when patients come in with spinal cord injury or stroke or COPD, they have a pathway to rehabilitation, certainly in Australia, and I know they do here as well in the UK. However, when patients are general medical or surgical patients, they just were falling through the cracks. So they go home and then there's perhaps fracture points from discharge to picking up when patients go back to their general practitioner and say, oh, I can't do this and I can't do that and I'm fatigued and I can't make dinner for my children. And that was certainly brought out by a very powerful essay by Cheryl Missack, who was a lawyer who had pneumonia, and it was published in the Blue Journal. So there are real patient issues, but the patients were falling through the cracks. So it was thought to be important to identify a syndrome or a phenomenon so that people could actually say, OK, we need to do something about this patient who's going home. Rehab, though, in the ICU is not easy. And any of you who've seen a patient try to get out of bed with drip strains, endotracheal tubes and so forth, you know that it's not easy. So as clinicians, we stand at the bedside, certainly as a physio, and say, oh, the patient's quite sedated, they're pretty unstable, they're weak, they're tired, they're confused, they're obese, it's too hard. So there has to be a culture in the unit and a culture within all of the staff in the unit for rehabilitation to really happen in intensive care. So what does the research tell us about what happens with rehab in the intensive care? And this is probably the most disappointing slide for me as a physiotherapist, I guess. What I've done, and I'm not going to go through all of them, is there's around 12 randomised trials now, and I've listed them all with where they're from. The top 3 or the top 4 that are shaded here actually started rehabilitation early in the ICU process, so within 72 days, although the definition varies around early. And the predominant one is the one published by Bill Schweikert in The Lancet, and the only surgical one, which was the most recent published. All of the others are either in medical patients or mixed medical surgical populations, but the one by Schaller from Germany was published in just surgical patients. Okay, so they're the early rehabilitation. The Burton one, they started at 14 days, and so that was really chronically, critically ill patients. But the Schaller paper was published in The Lancet, and this is only surgical patients, around 200 surgical patients who had Apache 2 scores around 16 or 17, so not super unwell. And what they did was they used a protocolised mobility program called SOMS, so the SICU, Optimal Mobilisation Score. And what they did was set goals for the patients with different levels, so no activity, passive movements, which I don't think are particularly useful, sitting, standing and walking. They developed up this SOMS themselves, they didn't validate it, and they also used that as their outcome measure. So what they did find, though, using this and goal setting for every patient at the beginning of the day, a difference in how patients functioned at ICU discharge. So it's an important paper with some issues, of course, but the other interesting thing they did was a communication strategy, and we were just hearing about communication with patients, but in the unit, a goal setting was posted above the bed, what that mobility was meant, hoping to be achieved by the patient for that day. So I think, it's a really interesting paper and certainly a positive paper, which is good. So all of the other papers that I showed you, except for those top ones, had, I won't say negative results, but equivocal results of their work. So the reason, well, lots of reasons, I think, and I think we could sort of couch the reasons for these perhaps not so great longer-term results. The papers with the best results had short-term measures, not long-term measures. All of those papers used slightly different interventions. They were different populations, very heterogeneous, and they used different outcome measures, as well as different comparators. So it's very hard to generalise our work in Australia and certainly here in the UK to the American work, because the first few papers from America in the control group, the comparator was 0 mobilisation, 0 physical therapy. They weren't moving their patients at all, and they were fairly heavily sedated. So for all of those reasons, those latter papers didn't show positive results. So in an overview of systematic reviews, we've had about a plethora of systematic reviews, level 1 evidence, around early mobility and rehabilitation in the ICU. And in an overview, it was found that if rehab's delivered early in the ICU, then you get improvements in short-term outcomes. However, for rehabilitation After the ICU, so when the patient goes home, there's really insufficient evidence at this time, although there have been about 5 studies to date, but not as many as in the ICU. The thing is, as a physio, I know that rehabilitation works. We know rehab works in COPD. We know it works in heart failure. We know it improves patient outcomes, function, health-related quality of life. So empirically, we know that rehabilitation works, and these are the reasons why rehabilitation works in the ICU. There are 10. It was published in ICM, one of the sort of 10 reasons why series. But you can see, looking at these, we know it's safe. There's been a huge systematic review with problems in around 2.6% of patients, so very, very small. This is probably important for this audience as well. We don't know for certain, but I'll talk about this in a moment around improvements in delirium. So some of the reasons why there might be differences in these papers. So Zudin Pathicheri and I looked at 150 patients from our randomised controlled trial, and we separated them into healthy trajectory, so no comorbidity when they came into the unit, and a morbid trajectory over here. It's a secondary analysis, so, the stats aren't great, the sizes of the groups are uneven. But what we found in the intervention group in the dark line here, the control group in the dotted line here, over 3, 6 and 12 months, you can see that there's more separation. So the patients with a healthy trajectory, so no comorbidity, actually did well with the intervention. If we look at the morbid trajectory here, all of the patients actually improved, the trajectory was slower and it flattened off. But there's not very much separation here between the groups. So we propose that we should stratify by morbidity to change trajectory and also to try and get separation, and that might be able to reduce our N in our randomised controlled trials. So this was one of the first sort of papers that suggested that comorbidity was important. There have been others, and this is an American study from Lauren Ferrante from Yale. So she found, and not unsurprisingly, that frailty is important. So that's months from ICU, that's number of disabilities, and this is the clinical frailty scale, frail, pre-frail and non-frail. And you can see here that patients with frailty was associated with over 40% disability up to 12 months after the ICU. So frailty is an important comorbidity. The other thing that is actually being looked at very significantly now is inflammation. So patients are coming in septic, inflamed, and the group in Edinburgh has looked very elegantly at the role of inflammation and its impact on mobility here. So that's mobility, that's CRP. This is measured at 3 months. And you can see that the patients who still have raised CRP at 3 months have worse mobility. And we were hearing yesterday at an RSM conference on critical care that they're actually doing more work in this field. But I think what this field is trying to do at the moment is to find the biomarker so that we can stratify patients and work out what we do in rehabilitation, who we rehabilitate and how quickly we do that. Cognitive function, important again in perioperative medicine, is shown here again by Lauren Ferrante's work. So Lauren Ferrante, the reason that she can have pre-ICU is that she's looked at thousands of patients in a big medical study in the US. And so this is a very similar graph showing that the mini-mental here makes a difference. So patients with moderate impairment on the mini-mental when they came into the ICU had a 20% increase in disability and twice the odds of going to a nursing home. So is cognitive function a biomarker for functional impairment? We don't know. There's lots of unknowns at the moment. So exercise and mobility we have. How do we do it? Well, we can use protocols as seen here and in the SOMS paper. We use all different sorts of exercises. So we've got a WeFit that helps cognitive function. We use supine cycling and we use strength and functional exercises. On the ward, we take patients down to the gym if we can and obviously encourage physical activity when the patients go home. We don't know which is the best exercise yet. We're still trying to work that out. We also don't know when we should time rehabilitation. We think we should start early in the ICU. We probably should continue it across the ward and then continue once they go to the community. But in Australia, we don't have post-clinical care clinics. So not yet. There are a few, but we don't have very many. So that's a bit different to here, where you do. So we need more research. We need more research about the intervention that we're going to be using. And we need more research around delirium and the effects of intervention on delirium, because all of these 3 studies have shown a different secondary outcome in delirium. We did a little meta-analysis and showed that using physical activity can reduce the number of days of delirium, which is probably the important thing, not just the one episode of delirium. And we know that 70% of patients in the ICU develop delirium that goes on to be cognitive impairment equal to mild Alzheimer's at around 3 to 6 months after ICU. So we do a lot of things in the ICU that aren't necessarily helpful. Just to finish, where does nutrition fit? I can't answer that question at the moment. There's many people in the audience who know more about nutrition than I do. But I think multimodal, in athletes, nutrition's important, exercise is important. We're really looking to multimodal treatments and perhaps more protein, less fat in the ICU. But whether we start that early or late, we're not sure. So really, thank you for listening. There's a lot of unknown questions in summary. We're searching for the biomarker so that we can predict who we need to start early with, who might we just put into slow rehab or palliative care rehab for that matter, and who we need to work really hard on. And ICU length of stay might be important, age, frailty, comorbidity, and then we need to work out exactly which intervention helps. And I haven't even touched on outcome measures. So we're doing some work around core sets of outcomes so that we can compare across studies. So we've got a lot of work to do in the future. I think in a couple of years, we probably don't need another randomised trial, a large one at the moment, until we've worked out all these other issues. Thank you.
Hi, it's Desiree Chappell here. Top Med Talk is the broadcasting arm of EBPOM, Evidence-Based Perioperative Medicine. Most of our podcasts from Top Med Talk are either presentations from the EBPOM conference or they're interviews with people who attend the EBPOM conferences. Have you always wanted to attend an EBPOM conference, but you are unsure because of travel, accommodation, costs, whatever it may be? This year, are you planning to respect social distancing and avoid attending large social gatherings while minimizing travel? Do you want to attend one of the most important medical conferences of the year without having to leave your home? Go now to ebpom.org and discover EBPOM Live from London. Get all the latest and greatest information streamed live to your home, office, or bedroom as you attend the conference virtually. Submit your questions, network, and hear these talks before anyone else in the world. In light of the recent COVID-19 pandemic, attendance for this conference is at an all-time high. We only have some limited spaces available. Carbon-friendly conferencing is here. Be part of the most exciting development in medicine since the invention of the stethoscope. ebpom.org.